So we are a Alzheimer's Caregiver Support Initiative, a grant awarded to Parker Jewish Institute in New Hyde Park. So basically our program provides free support and services to caregivers of loved ones with dementia. These services include care consultations, support groups, education and training, paid scholarships, volunteer respite, and memory cafes. I'm just going to briefly go over in a little more detail about what each of these services are. So our care consultations are where a licensed social worker will meet with you to discuss any issues that your family may be having or direct you to the appropriate resource that you may need. We have support groups. We have all different types of support groups, adult children, spouses. We have a men's group, also led by a licensed social worker that can help you with any issues. And you can also maintain friendships through the support groups as well. We have caregiver education programs, including this one that we are lucky enough to partner with Stony Brook Center of Excellence for Alzheimer's Disease. And we have many other programs that we do virtually as well. Some scholarships we provide. Scholarships for daycare, home care, or an overnight respite stay in hopes for caregivers to get a relief from the demands of care. So there's that type of respite. We also have volunteer respite care. Caregiver companions can provide 4 to 6 hours per week of respite care in the home. Most of our volunteers are vaccinated at this point. We are just opening up this program again. If they are not vaccinated, they are only allowed to do telephone support, but we are allowing the volunteers back into the homes again, which is great. Next slide would be, okay. We also have a caregiver ambassador program. My colleague Jennifer Roth usually would take care of this portion. She heads out to the libraries on Long Island and provides some resources and programs that we can offer. And then memory cafes, something that I coordinate. We have them all over Long Island at different restaurants where caregivers and their loved ones with Alzheimer's or other dementias can come and share their stories, have a free lunch, and we provide musical entertainment. It's a great way to connect with other caregivers. And that's about it about us. And this is our contact information. Feel free to give us a call or email. I'll also enter this information in the chat box if that's all right, if you missed this slide. And I'd like to hand it over to Dr. Absar.
Thank you so much, Jacqueline. Thank you for inviting me and our organization, and thank you to be a partner with you guys. So I would love to share my screen. Let me see if I can do that. All right. Can you see my screen?
Yes.
Okay. Slideshow from the beginning. Okay. So we are very excited in this time as a new hope and new era of Alzheimer's disease. We've been waiting for that for so long. So I'm going to touch a little bit about our new discovery of the new medication. But I also wanted to discuss the realistic logistic about the new medication and some of the struggle that we're still doing with that. And nevertheless, it is a huge discovery. It's a new hope for all of us working in this field. We've been waiting for so many years. So it is a big hope that brings us. And not only this, it also brings us a cascade of different futures. So a lot of other trials, which is almost ready to be accelerated for different, a similar FDA approval process started already because of this new discovery. So I'm going to share a little bit about that. But I also do not want to minimize whatever we have at this moment to offer for dementia, especially with Alzheimer's disease. So I don't want to make sure, I want to bring up all the things that we are offering right now, including the new medication. With that in mind, the first slide, I wanted to bring it up. I know everybody wants to know about the new one, so I put the slides right now. But I also wanted to disclose a little bit of difficulties with this new medication. So I'm gonna share it with you guys. And in the end, if anybody has if we have a time to do a little Q&A, then that would be good if I could get some of the feedback from participants if they wanted to answer any of the specific question. If anyone has more specific, then I'm going to cover it right now. Okay. So the treatment of dementia-related symptom, I divide them into two parts, so which I'm going to focus on. So the first slide is the treatment of cognitive symptoms, things that slow down the disease itself, okay? And then second part would be treatment of the associated neuropsychiatric symptom, which comes part of the disease, but it's so easy to fix sometimes. We have medication for that. So we have improving medication that can improve the quality of life for our loved one. So I'm going to emphasize on that more than the first slide, because the first slide, it was still kind of not clear where we are going into. But the following slide, we are pretty much clear what we have to offer. So I'm going to more emphasize on the following slide. But I know the anxiety, so I wanted to put this out for the first slide. So right at this moment, that way that we do the slowing down of the disease modification is by some kind of symptomatic treatment. So if you think about Alzheimer's disease, so Alzheimer's disease, as you know, the history was created by this neuropathologist, Alzheimer's, and based on his pathological findings of this amyloid based imaging, and later on added with a different protein called tau protein. So these are the biomarkers that we have known for some time now, that we know also from our previous research, I'm sure a lot of you are aware about, which was conducted by Alzheimer's Association and Center for Medicare and Medicaid, CMS, called IDEA study, which is based on imaging for amyloid PET scan that lasted from 2016 till 2015 till 2017, something like that. That was a huge discovery. We found out that people who were diagnosed clinically with Alzheimer's disease, later on when we did the amyloid PET scan, we changed their diagnosis. We found that they don't really have Alzheimer's. They have other form of dementia. And people who didn't think about Alzheimer's, we found they had amyloid in their brain. So this was a great starting point for all this medication that coming now. So this IDEA study gives us a lot of the resources, like what to expect from this new medication, new discovery. So I'm going to touch a little bit about that. But without the IDEA study, without this amyloid, without this tau protein, we still had a lot of things that we are offering for quite some time now, which is one of the major neurotransmitter is called cholinesterase inhibitor, which is basically an enzyme that catalyzes a chemical or a neurotransmitter in the brain called acetylcholine. We found out acetylcholine is one of the chemicals responsible for memory. And then the second chemical is called glutamate, which help with the receptor called NMDA antagonist. I'm not going to go details about more medical term, but basically what it does, it involved with immediate learning process, like immediate memory, registration, and coding information, like things that you are hearing from me, like your hippocampus, your memory part of the brain has a lot of these receptors that lighting up as I speak. So it get retained in your brain. And this is the glutamate reaction. So the cholinesterase inhibitor medication has been out for quite long time. One of the biggest one is the Aricept. Aricept, we all know, the generic name is donepezil. So donepezil and Aricept been there, and then we found out people who cannot tolerate donepezil because of stomach side effects or some kind of poor absorption. We also have a skin patch for that called Exelon patch. We know about them, and it works really, really well. We also found out that when you are taking it on a appropriate dose, especially it's been FDA approved for all three levels, mild, moderate, and severe level of Alzheimer's disease. When you combine them, when you work them appropriately, you can see some slowness in the disease process, disease declining process. So this cholinesterase inhibitor has been out there. Then we added this glutamate medication called Memantine, or the generic, the company name is called Namenda. As you know, Memantine work on this glutamate, which basically immediate memory. So when we did the research, some of the research, it showed when you combine them together, the Aricept and Namenda, we can actually slow down the disease process really well. And they talked about modest improvement, but we didn't have a long-term trial for that. So modest, I think, in my personal clinical experience, it can keep you where you are as long as possible. So it's a major discovery. I mean, I don't want to minimize those two medications because of all the newcomers coming, because we still have those two major discovery we can offer for a lot of our loved ones, to how can we slow down the disease process to keep you where you are as long as possible. So that's those two we already had. So the third one, which is the truly disease modifying agent, meaning it doesn't work on the neurotransmitter. It actually works on the molecular level. Like, remember the protein that we talked about, that the protein, the abnormal protein accumulation that caused the disease called Alzheimer's disease. So this abnormal protein accumulation, the amyloid, the tau, this is the agent that we've been looking for. How can we find out something that can either decrease the production of the amyloid, or it cannot decrease the production, but it can improve the elimination of the amyloid from the brain. So either way, we can decrease the burden of the amyloid from the brain so that we can clear the amyloid to see whether we can either slow down the progression or even if we can prevent Alzheimer's disease in the future. So that's our dream. With that in mind, we have several trials. We had success, we have failure, we have an up and down battle for the whole last 10, 15 years, even 20, 30 years that we started with this struggle. We did also a lot of emphasis on the other protein called tau protein. Unfortunately, we don't have a lot of tau protein discovery yet. But for the amyloid, the first one that we found out is the aducanumab, or the Aduhelm. Aduhelm, or the aducanumab, is one of the basic protein that monoclonal antibody that we know. We came out, and Biogen did two amazing clinical trials. They did two different clinical trials with two different dosing. One of the trial didn't work, but when they adjusted the dose and increased the dose, we saw some modest improvement in substantial decrease in the slowing down process. What we didn't see, it's completely reverse, but it can slow down significantly. Unfortunately, the clinical trial that we have done so far, we have researched so far with the Biogen information, is that it only can target it with the mild cognitive impairment, which is almost like a prodromal phase of the disease, meaning almost before you actually interfere with your actual functional skills. like activities of daily living skills. So when you still have the normal activities of daily skills and you have subjective memory, but you're not demented yet. So that stage, it worked really well as early mild dementia stage. We do not have any data for this medication for moderate or symptomatic stages where your cognitive impairment is pretty much pronounced. But having said that, I think this is a great discovery. So this is how it works. The medication Aduhelm works. It's a monoclonal antibody eliminating amyloid, and we can get at least 20 to 30% of the elimination of the amyloid. But again, it's not a cure. It can substantially decrease the progression of the disease. Unfortunately, there are a lot of complications that need to be clarified. So FDA did a accelerated approval process. What does it mean? It's an accelerated approval, meaning it's not really approved. It's a conditional approval. So there are some conditions FDA put it. One of the major condition is that they are asking Biogen to do a phase 4 study for the safety, as well as there are few concerns that we need to clarify. So I'm going to clear a little bit of go by each of those concerns. So the first concern is as we know, I started talking about the theories of Alzheimer's disease so much with the biomarker. Our hypothesis is mostly two protein abnormalities so far. It's called the amyloid and the tau. So these medications solely work on the amyloid only, does not do anything with the tau. So that's kind of a little bit of a kind of confusing part, because as we know, Alzheimer's is amyloid caused the disease, what we find out from our IDEA study. And most of the tau burden or increasing tau, which progress the disease. So one protein abnormality is real cause, and then the other one make it progress. So this is a little limitation that we're only targeting on one amyloid or one protein. And also, it's a lot of clinical eligibility. I'm going to talk in a little bit that needs to be clarified, that who are the people who will be eligible for this study. So in order for us to do a major medication, which has a lot of risk involved, including side effects, I'm going to talk about that. But if the benefits outweigh the risk, it is a worth trial. So I don't want to minimize that, but I also wanted to not to minimize that we need to clarify how do we choose the people, not only for the trial, but also the people that may have more side effects, meaning the major side effects that we know of is called ARIA, ARIA or ARIA. It stands for amyloid-related imaging abnormality. So what does it mean in English, in simple English? It means this amyloid, which is hyperviscous, sometimes can stick the bloods together and can cause some microhemorrhagic symptom. So they found that these medication can cause microhemorrhage that can be symptomatic sometime, or that can even not be symptomatic sometime, but that can have a delayed lethal effect. So we have to carefully monitor those by doing, several MRI study just to make sure you do not develop any of those area kind of abnormalities or imaging abnormalities in your brain because of that. And we need to exclude people who already have microhemorrhage, or who already have stroke, or who already have tendency to have hemorrhage, including people who are on anticoagulant, for their heart problem or something if they have microhemorrhage. So the FDA doesn't really give us a lot of guidance about those, how to exclude people. It doesn't really give us the prescription guideline for contraindication of this medication. So that needs to be clarified by FDA. That needs to be clarified who are not to be eligible. So one of the biggest non-eligible people would be, there is a type of amyloid-related stroke or microhemorrhage. It's called CAA. I don't know how many of you remember, a lot of our patients can get similar dementia from CAA, which stands for cerebral amyloid angiopathy, which is very similar to Alzheimer's disease. They also have amyloid, but their amyloid is deposited in their blood vessels, and it can cause, remember we said amyloid is a hyperviscous, and sometimes it can cause stickiness and hemorrhage. So they cause spontaneous hemorrhage and like a mini stroke, multiple stroke. And these are called, this is a syndrome called CAA, or cerebral amyloid angiopathy, which also can cause dementia. So even if you do the amyloid PET scan to diagnose Alzheimer's, we really cannot often differentiate who has pure Alzheimer's or who has from the CAA, So there's a lot of confusion. How do you exclude people with those kind of vascular disease, as well as people who just had a major stroke or who had a lot of high risk for stroke? So FDA did not have any contraindication for those vascular disease. How do you exclude them from this clinical trial? As well as anybody who has a comorbid vascular dementia, they will be automatically excluded. Also, if somebody has a combination of, as you know, before I go any further, even with the Alzheimer's disease, most patients with Alzheimer's end up with mixed dementia, because as we get older, we also get vascular disease in our brain. So we'll end up with Alzheimer's as well as vascular dementia together sometime, and it's called mixed dementia. So with this clinical criteria, if you have a vascular disease, you will not going to be eligible for this trial because of the potential for, amyloid-related imaging side effects, those kind of microhemorrhage or brain swelling. So this is a big problem, that whether it's the benefit outweigh taking a big risk to have this kind of side effects. So this is something to be really clarified before we started to offer everybody about this medication. The third biomarker we also wanted to add on, and this is something not added, is whether, remember we talked about two protein, amyloid and tau. So we have a biomarker for amyloid. We can do lumbar puncture. We can see these, amyloid beta protein in our CSF. We can also see tau protein in our CSF from lumbar puncture. But in terms of the tau protein, the PET scan, the PET scan, which is a scan similar to amyloid, is not available yet, other than research for tau. So we don't know how do you screen out people who have a tau protein abnormalities in the brain. Only way we can do, there is a biomarker coming, is a blood test, simple blood test, that can actually very reliably see how much is your tau protein burden in your brain. Because I know that more you have the tau protein burden in the brain, it can also reflect how likely you get the benefit of the medication. So this is another FDA big challenge to add on another biomarker test for tau protein. And the third biomarker they also had to amend is there is a biomarker we know is called NFL, neurofilament light chain. Neurofilament light chain is a protein that is not specific for Alzheimer's, but it is specific for any degenerative brain disease. So that's a very simple test. You can do a blood test and you can actually see if you have an elevated NFL, neurofilamentous light chain, and that determines whether you have any neurodegenerative dementia or not. So those are the three biomarkers can also help us not only to exclude people who doesn't have Alzheimer's, but also to see who are the patient with early Alzheimer's disease will get the most of the benefit. So we can take a risk, even knowing that abnormalities of microhemorrhage and all kind of other stuff, that we can monitor them with MRI and with other clinical monitoring, but we can take a risk because the benefit outweighed the risk. So those are the things as a big challenge for FDA to amend. As I said, the contraindication who are not eligible for the study, who are the people who will most likely get the biggest side effects. So we have to identify their vascular risk. We have to identify any comorbid dementia. We also have to identify that who are the people that we need to monitor closely because they may get more area like the imaging abnormality defect. So we have to do more MRI during this process. And then another real problem is, as you know, a lot of people cannot take MRI. Also, we have a lot of modern technology nowadays, that a lot of pacemaker, that if you have previously, anybody who has a pacemaker cannot have an MRI, as you know. So if you can't have an MRI, you can be eligible for the study because the MRI is essential to rule out any of those imaging related abnormalities like microhemorrhage or brain swelling. We have to have the MRI in a certain schedule, like before starting the treatment, and at the height of each dose increase, we have to have an MRI just to make sure before we increase the dose, we have an evidence that there is no hemorrhage, there is no microhemorrhage in the brain. So if somebody has not the older version of the pacemaker, then they cannot have the MRI, meaning they cannot be eligible for the study. So there is a lot of confusion, who will be eligible, how can you screen them, how can you minimize those abnormality, and finally, how do you make that eligible? So I know I don't want to make it depressing, but for now, the study only showed that the CDR, they have two different scales they do in clinical assessment. One is called CDR, Clinical Dementia Rating Scales. It's basically a bunch of testing for memory. It's a memory testing. And then they also have a caregivers questionnaire. We call it sum of boxes. Sum of boxes, meaning they have several boxes of behavioral monitoring symptoms. So they may ask the patient that, would you do something in public that will humiliate you? Or would you do something sexually provocative to other people in public places? The idea is to rule out other dementia like frontotemporal dementia or anybody with Lewy Body Dementia who may have visual hallucination. So this is the idea. How do you eliminate non-Alzheimer's dementia? So we can narrow it down to patient only for Alzheimer's disease. So those, what they showed, it's only work on CDR 0.5 and mini mental state examination of only around 26 or less, which is, they say about 20 to 26, but in real life, they say that most of the patient that was in the study have a mini mental around 26 or above, which is very much almost like, at least in my clinical setting, in my clinic, very few patients will be eligible for the study because most of the patients that I see, they're symptomatic because they come to see me because they already have a symptom. With that, they already have early dementia with a mini mental stage, at least less than 25 or 24 or something like that, more often less than 20. So they will be automatically excluded. So those are the really struggle that is. Do I still get hopeful? Absolutely. I think it's a huge discovery. So what FDA wanted to do is an accelerated approval, meaning they're giving the company time to do additional phase 4 study to do all the things that I discussed, all the problem that I talked about, to make that happen. And if they can do that, then on condition, they will do the final approval. In the meantime, because of this discovery, we have the second medication from the Eli Lilly, Those are the, is in my slide here, donanemab. This donanemab is the next one coming, and they already applied for accelerated approval by the late of this year. They may come out anyway. So they might be even getting benefit more than Biogen has. So this is a good competition, because this is a good way to having more and more amyloid-based real medication for Alzheimer's disease. So it is a miracle what we are expecting. It is a miracle. So although it may slow down a little bit of time, but it's worth waiting for it, because we don't want to too much rush. We don't want to start something without knowing what are the risk factors, who are the people who can have a bleed in our brain, who will be eligible, how can you make sure we don't get the bleeding, how can you make sure we don't get, we get the maximum benefit. So because of that, I think we should not get depressed. We should not get discouraged, even though it may take some time to clarify everything. I'll be happy to answer any of those questions about this new medication. But this is the, in a nutshell, this is basically what I wanted to share. So basically the biomarker, which is the amyloid and tau, that needs to be clarified, because we're only targeting one. We're not targeting both. So we have some limitation. With that limitation, we also wanted to maximize who are the beneficiary. So we want to make sure we can screen people with not only mental state exam, not only cognitive exam, also with the lumbar puncture, with the amyloid-based biomarker, with a PET scan with the amyloid-based biomarker. And maybe we should add those two other biomarkers that I talked about, the tau-based biomarker, like a blood test, as well as NFL-based biomarker for neurodegeneration that I talked about, so that we are targeting the exact population. We are knowing that who are the people who will get the maximum benefit. And the second summary that I wanted to make out to you, make sure you remember that what I said, how do you make the eligibility criteria more broader? How do you screen them more broader? How do you screen them so that we know who are the people who will get the benefit? And the third, how do you minimize the side effects? How do you monitor them? So those are all the things that we need to do. And then finally, I have to say, we need to have a big teamwork. Like the way, if you remember, I was part of the IDEA study, which was the 2015 to 2017, I think, that we involved with the Alzheimer's Association and the Center for Medicare and Medicaid, which involved with this amyloid PET scan. That was the biggest study. That was amazing study that gives us all the hope that bringing up all the new medication now. With that study, we learned that no matter how you clinically diagnose, when you do those kind of imaging, sometimes it changed the diagnosis. So this is why this imaging is so important, or the blood test, other biomarker is also so important to, before you start this immunotherapy, which is a pretty intensive therapy. Once a month is a monoclonal antibody therapy. We need to have an IV infusion. We need to have a dedicated IV team, like a cancer oncology team, like a cancer, almost like identical to cancer team, that we need to have a teamwork. We need to have a nurse, dedicated nurse practitioner who does monitor for all the IV infusion. We need to have a good dementia specialist doctor who can read scan, who can clinically identify the symptom, who can make sure you are safe, you don't get all those side effects. One third one, we have to have a dedicated social worker, psychologist to counsel patient, genetic counseling about before we start the medication treatment. So we need a lot of clinical work, like a teamwork build up in every academic hospital. And also, how do you spread out to the community? So that would be a struggle. How do you do that? So with that in mind, I want to focus on something other than that we already have. So I just wanted to keep, I'm very optimistic doctor. I don't want to minimize my optimism. And I feel amazed by this new discovery, but I think it's worth to wait and let the scientists and the doctors do all those work to make sure it is safe to administer, make sure it is safe and it is minimizing the side effects, including those kind of serious side effects that we talked about. And also make sure we identify who are the people, the maximal beneficiary for this medication. Okay, I'll be happy to answer anything if you have, but because of time, I want to move on to other aspect of treatment of dementia related symptom, and this is going to be the neuropsychiatric symptoms of dementia, which basically comes with depression, lack of motivation, hallucination, anxiety, obsession or compulsion, and sundowning like agitation, disinhibition. What can we do to help them? Behavior in dementia patient can be very much multifactorial. So I would, rule of thumb is never start a pill unless you investigate what is causing the symptom. So please make sure you see a physician who specializes in dementia. Make sure you're not popping up a pill without knowing what is causing the pill, because some of the behavior symptom can be caused by just environmental stimulation, like overly stimulated environment, having our loved ones sitting in a milieu with thousands of people screaming and yelling. That makes them very overly stimulated and agitated. All you need to do is isolate them, take them out of the overly stimulated environment, and they may not need any pill anymore. So environmental modification is a big one. Second one is the sensory modification. If somebody doesn't hear good, doesn't have a hearing aid, somebody doesn't see well, doesn't have a good vision, that they can misperceive things from the reality. They can get confused. They can get agitated because they are not perceiving what's going on around them. So the correction of hearing, correction of vision is a paramount importance for behavior symptom management. Third is the medical causes. Most of these abrupt changes in behavior, including hallucination, confusion, delusion, or aggression or agitation, sometimes caused by medication related, too much medication, polypharmacy, or infection, simple things like UTI or dehydration or pneumonia or any kind of toxicity from other medications. So we need to do a blood work to rule out any kind of metabolic problem like low sodium, liver function, kidney function problem, because that can cause delirium. This is called delirium. This is not dementia. So delirium is an abrupt onset of confusion and agitation or behavioral changes for a person with dementia. So we got to differentiate what is dementia and what is delirium. So that's why delirium workup, which is a medical emergency, if somebody has an abrupt confusion or abrupt change in mental state, they need to go to the emergency room or urgent care to get that workup done, to do some blood work, make sure they have a routine test done, urinary analysis, chest x-ray, to rule out those causes. And the symptom of treatment of those behavior would be, if they are dehydrated, they need IV fluid. That will improve their behavior. If they had UTI, they need antibiotic. That would improve their behavior. If they have too many medication causing those confusion, remove those medication that was causing. Those are the easy thing to fix. But if you don't fix it, if you don't diagnose delirium, it can cause early mortality, early death because of undiagnosed delirium. So this is a really, really paramount importance for everyone to screen delirium in a patient with dementia, okay? Next thing is, there are different problem in the cognitive impairment that looks like behavior, but it's really not a behavior problem. So I always give an example of my days in Maryland. I was at the Hopkins and I was doing one of the nursing home a supervision for medication management. One day I got a call from one of their nursing home that one of the patient was getting agitated and angry because her neighbor, or not neighbor, the person who sits next to her in the dining room always eat from her plate rather than her own plate. So they get fight and they need medication. So the nurse was calling me for medication for their behavior. So I don't like to give unnecessary medication for dementia because I know that medication has a side effects and can cause more confusion, more agitation unless you need it. So I said, I don't want to see them first before I prescribe anything. So I went there and I said, does this lady always eat from other people's plate from the right side, or does she eat somebody's who's sitting on the left side too? They said, no, only on the right side. I said, huh, that's interesting. She doesn't, interfere or doesn't get mad or eat some food from the other plate who's sitting on the left hand side. I said, okay. So I moved them out and I moved them around and I said that, all right, now she's sitting and nobody's from the right side, everybody on the left side sitting in the dining room table. She doesn't do anything. So I gave them some cognitive testing as a simple test, like a clock drawing test, or sometimes you draw a line and you ask them to bisect the line right in the middle. Those are the two simple tests. Anyone can do that. So I did that. Guess what? I found out she has what they call hemi-neglect syndrome, meaning she has no vision on the right, one side of her visual field. It's called neglect syndrome. This is from a stroke, from dementia related stroke that she had. She had a vascular dementia. So she only see half of her plate and she see half of her neighbor's, right-sided neighbor's plate. So when she eat from the right-sided neighbor's plate, she thinks it's her own plate. So she's eating from her own plates, but she's actually eating from the neighbor's plate. So here is the behavior problem start. So I told the nursing staff that patient does not need medication for behavior. You guys need more education to make sure that patient, what is neglect syndrome, so that you don't put her in a situation when she has somebody sitting on the right-hand side. So she will eat from their plate. So you give them a single table so she doesn't bother anybody. And that happens and she doesn't have any problem with behavior. So these kind of things need to be screened out before you pop up a pill, okay? Because these are the neurological deficit. You cannot change a pill to change that, okay? We need to modify the environment to improve that, so that we need to learn about dementia. Every CNA, everybody who take care of our loved one need to be educated about this neurological term. What is neglect syndrome? What is visuospatial problem that leads to behavior? So this is why the education for our healthcare staff is so important, so that our loved one get the proper care they need. And then after all those, if we have symptoms, then of course we need to find out what is the symptom that we're treating. If it is a mood problem, depressed mood, then of course we have certain medication that can help with the depression. If it is a change, not so much depression, but so much like a zombie, that they're not depressed, but they're not doing anything, we call that apathy syndrome. Apathy is a lack of a chemical called dopamine. And the medication for dopamine is different than regular antidepressant. So that's why if you put them in a regular antidepressant, like most of them are SSRI, meaning serotonergic medication like Zoloft, Celexa, Lexapro, it doesn't work for apathy, because apathy, you need dopamine medication like bupropion, like amantadine, like pramipexole. Those are the medication improve the dopamine level. So that's what the important thing. Sometimes we need to identify what are we treating. We need to understand what is the symptom rather than blindly give us a pill to our loved one. Third one is the perceptive symptom like hallucination. Hallucination often can be a first symptom of dementia. I'm going to talk a little bit about that, which has a lot of medication that we can do. But certain medication can cause Parkinson's disease, because we already have patients who has dementia. We don't want any other side effect. And also some of these antipsychotic medication also have FDA guideline for that. They're not recommended for patients with dementia because that can cause significant vascular disease. So we have to be using that in a proper way. So we don't overuse them, and we use them only when we need to. So basically everything on this slide is everyone to take a good history and examine the patient before you give a telephone order for a pill for anybody for behavior associated with dementia. So the idea of everything I said so far is do not treat the symptom, treat the disease or what are the cause of the disease or symptom. So if it is a UTI causing the symptom, give them an antibiotic. If it is dehydration causing the symptom, give them an IV fluid. If this is a symptom caused by Lewy Body Dementia, then we have to have very specific medication for those hallucinations rather than anything else. So this is what, if it is an apathy, we need a dopamine medication. So this is why it's so important to have an evaluation for those symptoms rather than just giving a pill. And as I said, the environment needs to be modified. The ear problem like hearing loss, vision loss, those needs to be, delirium needs to be ruled out, medical causes. And we need a multidisciplinary team to talk about that so that we can discuss among everybody in an assisted living or a long-term facility who can participate in this kind of treatment planning. And depression, sometimes it is a cause of the frontal lobe problem. So it's not so much psychologically we see in psychiatric patient. Depression is a disruption of the circuitry of the brain from frontal lobe to the subcortical region. So depression can be first symptom of certain dementia, including vascular dementia, where depression is the first symptom of vascular dementia. Depression can also mimic dementia. So when you give somebody with a depression meds, they can actually get better. So depression can be many phases. It can be the symptom or it can be the cause of dementia. So we need to, that's why, find out what kind of depression they have. And we need to also correlate the brain anatomy, like the circuitry of the brain with the clinical symptom. And that's why you need a doctor who can specialize in both the neurology aspect and the psychiatry aspect to correlate these two together, a real dementia specialist to understand what brain circuitry and what are the clinical symptoms are patient having, how can they correlate, and what would be the best way to treat them rather than just blindly giving a pill, because these pills comes with the side effects and all the risk and benefit. We need to maintain that risk benefit analysis all the time. And also there are a rule of simple thumb. If if you have a right-sided brain injury, often you see a lot of the mania, like a lot of depression is actually like a manic depressive episode. Most common stroke is the right side of the thalamus, or any kind of right-sided stroke can cause mania-like symptom, whereas left-sided stroke sometimes more cause depression-like symptom. And mania can be, I don't have to go through the details, but it can be from a lot of different things. In psychiatry, the mania that we see called bipolar disorder is basically what we call primary mania, meaning we don't know how that happened. It's mostly either multifactorial or genetic. But in neurology or in dementia, we see a lot of secondary mania, meaning they're not biologically born with bipolar disorder, but they can get similar bipolar-like symptom because of neurological trouble, or maybe a stroke or an infection or inflammation or dementia. So they can get the similar kind of symptom. And as I said, we need to differentiate what is apathy and what is depression. Depression, as we know, we don't normally miss that, but apathy, we miss that because apathy is lack of affect. It's like a sitting there doing nothing. You will probably, everybody can relate somebody in your life that you ask them, are you depressed? Why are you not doing anything? They will say, I'm not depressed. And you ask them to do something, 5 hours later, you come back, they're still sitting there, staring at the window, doing nothing. And that's called lack of motivation, lack of affect, lack of initiativeness, lack of drive. And that is the pure apathy syndrome. Apathy can be a lot of different ways you can get. It can be a manifestation of frontotemporal dementia. It can be a symptom of advanced Alzheimer's disease. It can be a symptom of vascular dementia or even Lewy body dementia. So that's how the diagnosis is so important when you see someone with apathy. And then the vascular dementia that I talked about, where depression can be the first presentation of that kind of depression. I always tell my medical student and my resident, I created this mnemonic so that they can remember better. It's the syndrome of 3M. I want you to remember that way, so you'll never forget. How do you screen for vascular or some of the dementia called subcortical dementia, which is different than Alzheimer's disease. Alzheimer's disease is called cortical dementia, where cortex means frontal lobe, parietal lobe, temporal lobe, occipital lobe. These are cortex. So anything that shrinkage in that cortex, we call cortical dementia. Example of cortical dementia is Alzheimer's disease and frontotemporal dementia, whereas subcortical dementia is endless. We have a lot of subcortical dementia example. Anything sub means under. So anything under the cortex is subcortical dementia. So think about anything that part of the movement part of the brain, like Parkinson's disease dementia, Huntington's disease dementia, Wilson's disease dementia, vascular dementia, multiple sclerosis dementia. These are all examples of subcortical dementia. All of the subcortical dementia, including vascular dementia, they never start with memory problem. So if you talk to their family, what was the first thing they noticed about their loved one? Unlike Alzheimer's disease, they will always say, you know what, my loved one doesn't have memory is the first problem. They actually had depression or lack of motivation or apathy. They just lose the interest. And then they started having this problem with their movement or motor. So it's a mood, movement, memory, 3M. So the first M is always mood problem, depression or apathy or personality change. Second M is the movement or motor symptom like tremor or walking problem. So these are the people falling a lot, unsteady gait and walking or having tremor. Third M is the memory, but their memory is only short-term memory. They can remember things happened 20 years ago, but they don't remember what happened 5 minutes ago. So they're very ultra short acting. Their main problem is the executive functioning, meaning day-to-day functioning. Like how do you have a multitasking? How do you go to a shower with a soap and a towel and come up after rinsing and soap and everything? They go there, they put the soap, then they forget what to do next. They stay there, they come back without rinsing, without having any cleansing. So you have to share them. So these are the people with a severe executive dysfunction, day-to-day functioning problem. But if you ask them for long-term memory, they remember everything. So this is the 3M, mood, movement, memory. First thing is the depression. They always go to a psychiatrist, not any neurologist or neuropsychiatrist, because they have nothing to do with memory, at least for the first 10, 15 years. Then they started having falling, movement, gait, tremor. That goes on for another few years. Then they started having this short-term memory problem, but mostly problem with executive function, like day-to-day functioning. And this is, if you see someone like that, they need a cognitive evaluation, they need an MRI, and they really need to have a diagnosis of vascular or any kind of other subcortical dementia. Remember, I talked about Parkinson's, Huntington's, MS, all kind of other form of dementia that we have. So this is in a nutshell, 3M, mood, movement, memory. And this is the disease that comes with it, like Parkinson's, Huntington's, Wilson's. Lewy body dementia is a mixed type of dementia. It can be classified with a cortical as well as subcortical because it's really complicated. It's one of the disease that comes with a lot of visual hallucination, intermittent confusion, and there's something like a dream enactment behavior. So they act out of dream. So these are the people, they start with sleep disorder. And if you talk to their partners, it's always worthwhile to talk to their partners rather than the patient, because you get the true story. So sometimes I ask the partner, do you guys still, sleeping together? And she will, or he will say, hell no. I said, why not? He said, he's been kicking all night long, so I sleep in a different bed now. So they are acting out of their dream. So this is the nice way of, you can actually do a nice video. If you have an iPhone, you can do the video in their sleep. You can see how they are acting out of their dream. They're punching, they're doing this in their dream. And that's one of the biggest symptoms, signs and symptoms in Lewy body dementia. years before they start cognitive impairment, sometimes they start with that. And then they started having this intermittent confusion, meaning they goes back and forth, almost like a delirium. They, if you call them at 9 a.m., they're fine. They're so lucid. But if you call like at 2 p.m., they're completely confused. I had a patient who was a neuropsychologist when I was in Boston. He was a neuropsychologist by himself, PhD, and he developed Lewy Body Dementia. And he was going from one end to the other during one day. He comes back to the nursing station with a pair of underwear. He doesn't know whether the underwear goes to the head or to the leg, and he's a PhD. And it only lasted for a couple of hours, then he becomes normal. So that kind of abrupt waxing and waning confusion is a major criteria for Lewy body dementia, as well as visual hallucination with a dream enactment type behavior and spontaneous Parkinsonism. So they're not Parkinson's disease. They have some tremor or some changes in their walking or gait or slowness in their movement, but they're very sensitive with medication. So we see that in Lewy body dementia, the Aricept or donepezil has not only improved the memory, it's actually improved the hallucination and the confusion sometimes. So it's one of the biggest miracles that I am very much into starting right away donepezil or Aricept after I diagnose Lewy body dementia, because a lot of the behavior symptoms also get improved with Aricept. And then, of course, there are strict guidelines for those hallucinations. Most of the rule of thumb is if the visual hallucination doesn't interfere with your life, leave it alone. Don't do it. Because some of the hallucination is not unpleasant for the patient, because the risk and benefit, the side effects of this antipsychotic medication sometimes is so bad that it can outweigh to do anything, but sometimes it can be distressing. So in that case, we do have to treat them. Fortunately, now we have a new medication that is FDA approved in patients with Parkinsonism or Parkinson-like syndrome called Nuplazid. Nuplazid does not interfere with this movement disorder symptom, so it doesn't cause worsening of movement disorder. And then old antipsychotic that we have, clozapine is the gold standard. It really one of the best medication in Lewy body disease. And if you can't have clozapine because you need a lot of restriction, like a weekly blood work and all kind of stuff to monitor side effects, it's hard to do it for our dementia patient. So in that case, small dose of quetiapine sometimes is okay, but regular antipsychotic is avoiding is better way to do because of the potential side effects. And these are some of the slides that we can see different type of dementia. There's a PET scan. We can really nicely, we can rule out Alzheimer's disease from various diseases like frontotemporal dementia. If you can see that lesion when it's in the frontal lobe and the temporal lobe, we call it FTD or frontotemporal dementia. When it's in the memory part and the spatial part of the brain called parietal lobe and temporal lobe, we call them Alzheimer's disease. If they are in the back of the brain called visual cortex problem, we call them Lewy body dementia. So this PET scan can be a really nice way to diagnose early, whether it's a frontotemporal dementia versus Alzheimer's disease versus Lewy body dementia. And Medicare pay for this one. So that's really a good test. This was a scan we used to do before PET scan got reimbursed by Medicare. It's called SPECT, S-P-E-C-T, SPECT scan. And this is the patient, one of my patients with the severe frontotemporal dementia patient, that you can see the less lightening light at this area of the front part of the brain completely gone. And this is the frontal and temporal part. And this is a patient with advanced frontotemporal dementia. You can diagnose so clearly, So the way that I was talking about selecting medication, and again, this is just a summary, how important it is to diagnose somebody. And in a rule of thumb, in older age or geriatric pharmacology, always we need to start slow and go slow. So that's why you need a specialist who understand our loved one like dementia as well as geriatric specialty. So not to rush, not to give too much medication right away, because it can cause side effects right away. There is no rush. If we can slow down and start slow and go slow, that we can minimize a lot of the side effects. And, selecting medication considering who will be the person who will get most of the side effects, so we can personalize the medication. Everybody, we can't just have a one rule fit for everyone. We got to personalize medication for each patient, even with the same symptom. So we need to make sure. And then finally, the sundowning, we need to identify this is a circadian dysregulation of lack of melatonin, dysfunction in the brain. And that can cause this evening agitation or nighttime agitation or alteration in the sleep-wake cycle. But in the end, I'm going to stand these in the end that, with the Buddha's message that, we have to be happy for who we are. A disease cannot define who you are. You are who you are. You always have to be happy for who you are. This slide said that, Buddha said, you're not going to take anything to grave. There is only three things matter in life. Number one, how much you loved. Number two, how gently you lived your life. And number three, which is the hard one, even for me, is that how gracefully you let go things that does not serve you anymore. So we got to let go. We can't fight with the diagnosis. We have to accept the diagnosis. It's no point focusing on negative things, that why I can't drive anymore. I need to drive. Why I can't drive? Why I can't do this? Why I can do that? And struggle with the loved one. It is what it is. And we just have to slow down the disease. Do everything we can. How do you minimize the disease? With that, I will stop. Thank you very much.
Thank you so much, Dr. Absar. That was wonderful. Again, if anyone is caring for someone with memory loss or Alzheimer's, please feel free to reach out. I'd like to thank everyone for joining. And again, thank you, Dr. Absar and Daphne. Have a great evening, everyone.
Thank you.
Thank you so much. Bye-bye.